important topic. I mean, somewhere during your final examination, either in theory, long case, short notes, or in Viva, everywhere, somewhere, each of you will face something about this disease. Have you been covered? Has it been taught to you before? Acute pancreatitis? Okay. So you know there is one organ that is called pancreas. For every important thing, you need to know something about a little bit of surgical anatomy. Because we read anatomy with a different perspective, we read a lot of things, but what is relevant to the surgeon or surgery, we do not pay any interest to that. But everywhere, whenever you are talking about colon, some bit of anatomy will be required. So as you know, pancreas is an organ which is an exocrine and endocrine organ. Endocrine part releases insulin, the exocrine part releases some enzymes which are important for the digestion of our food stuff, especially trypsin that actually digest our protein part, and there is something called lipase that is involved in the digestion of fat. So these two enzymes are very important for our clinical diagnosis of a condition of acute pancreatitis. You know, pancreas has got four parts. It has got a head that is accommodated within the cilium of the duodenum. Then there is a part called neck. Neck is that part which overlies the superior mesenteric vein, portal vein. Okay, so on the vein, not artery. So neck is the junction between the body and the head, and the neck is defined that lies anterior to the superior mesenteric vein. So anything to the left of superior mesenteric vein is the body of pancreas, and there is something that goes into the hilum of the spleen that is called the tail of the pancreas. And always in the head there is a prolongation that goes behind the superior mesenteric vessel, that is called the uncinate process. So uncinate process is taken as a part of head, but it is not actually a head proper, because when you talk about carcinoma, carcinoma of the uncinate process and carcinoma of the head, they are different. But head and uncinate process, neck, body and tail. Its blood supply usually comes from the inferior pancreaticoduodenal artery. This inferior pancreaticoduodenal artery is the first branch of the superior mesenteric artery. That is very important when you will be asked about Whipple surgery, the curative pancreaticoduodenectomy done for pancreatic cancer. This inferior pancreaticoduodenal artery is very important. So the main arterial supply to the body and head comes from the inferior pancreaticoduodenal, and of course it is being supplemented by the superior pancreaticoduodenal, which is a branch of gastroduodenal artery. So this bit of anatomy you need to know. So we are going to discuss about this disease. This is a very important disease because it will come in the differential diagnosis. Apart from passing exam, from a societal perspective, lot of patients suffer from this disease, and it is a killer disease in unfortunate cases, and it is a confusing disease. Not everything is in black and white about this disease. So when you will be reading the books, there will be conflicting things that SAS said this, but the book says that. So there will be some areas of confusion which I will highlight and try to clear them up. Pancreatitis, just like appendicitis, is a condition of inflammation of the organ. Now, if I go the next, what causes it? I mean, this is the area of confusion. What? Yeah, but what actually causes it? Why it happens? Yeah, that's what there are multiple theories. There is no clear-cut infection. Like appendicitis is caused by an infection. But can you say that pancreatitis is caused by one particular infection like cystitis or pyelonephritis or cholecystitis? It is not like that. It is not infection, it is an inflammation. There are a lot of theories are there. But one thing is certain, and that you should remember. You said there will be multiple neural theory, ischemic theory, autoimmune theory. All these things are important. But how exactly it happens, nobody knows. So that's why I have put a big question mark. This is an area, but one consensus is there. Whatever is causing it, there is activation of the pancreatic enzyme abnormal activation of pancreatic enzyme within the acinar cells of the pancreas. You know, pancreasের যেটা গ্ল্যান্ড গুলো এটা ধর একটা মেন প্যানক্রিয়াটিক ডাক্ট, আমি একটু দুটো মাইক্রো আর মাইক্রো মিশিয়ে দিচ্ছি। সো এখানে কি থাকে, ছোট ছোট এরকম অনেকগুলো অ্যাসিনা থাকে, তাই না? এই অ্যাসিনা থেকে একটা ছোট ডাক্ট এসে মেন প্যানক্রিয়াটিক ডাক্টে যায়, and this is not representational, microscopic is too big for this whole pancreas. I have done two ducts. This is called the main pancreatic duct and this is the accessory duct. Main pancreatic duct is, it is ulta. Yes, so আমি যদি বলি, আমি তো তোকে কোথাও বলিনি যে এটা, so actually it should go above, but normal anatomy variations can happen. So this duct is called the Wirsung and the accessory is called the Santorini. So what I'm trying to say, these are the acinar just like lung alveoli, from where the pancreatic enzyme is secreted in an inactivated form. So then they come into the pancreatic duct. There they stay inactivated. When it opens into the major duodenal papilla, এখানে এসে এটা duodenum C loop, and in the junction somewhere, this is the, so this is the bile duct, gallbladder, right and left duct, and the common opening is guarded by a sphincter that is called the sphincter of Oddi. So what happens, these inactivated pancreatic enzymes in the gene form like trypsinogen, that is not activated, so they come right into the duodenum in the inactivated form, and there they are activated by the bile exposure to bile. They become from trypsinogen to trypsin, then they become active. So that's why the pancreas acinar cells are not damaged. But the basic consensus of pancreatitis is that somehow there is an abnormal activation of this precursor pancreatic enzyme to its active form within the acinar cells. Thereby, this is also made of flesh. It starts auto-digesting the whole pancreas itself. This is a consensus. But there are a lot of theory. Those theory you can write for the neural theory, autoimmune theory, and all these things. But there are some certain etiologies are very important. দুটো etiology কোনোভাবেই ভুলবি না। A majority all over the world, about 80%. Okay, so let's go to the etiology. Okay, আমি পড়ে যাচ্ছি। etiology, দুটো etiology ভোলা চলবে না, একটা হচ্ছে গলস্টোন আর একটা হচ্ছে অ্যালকোহল। So যদি কোনোগুলো মনে না থাকে, 80% of all pancreatitis is caused by either gallstone or of alcohol. Second one is alcohol. Third one is the drugs. You remember this pancreatitis for clinics, in 80% of the cases of pancreatitis, it is a very innocuous, harmless disease, little bit of pain, little bit of discomfort in the epigastrium, spontaneous resolution. Lot of patients don't even come to hospital, they think there is a bit of gastritis or stomach upset and they heal by themselves. So 80% of the disease is very innocuous. It is only the rest 20% that we are worried about, because you see you need to know some statistics. In the rest 20% cases, there are different kinds of gradation of pancreatitis, but combined mortality of those 20% who are not that innocuous, the mortality is as high as 40%. So out of 100% coming to hospital with pancreatitis, so 40 will die. Okay, so that there lies the importance of pancreatitis. But at the same time, majority of them is innocuous. They don't do much harm. Third is the drugs. You probably in the pharmacology you have read that lot of drugs, any drug you mention, it will be right. So, but couple of drugs are very important. First is azathioprine. That is a cytotoxic drug. So that very consistently causes pancreatitis. Second is steroid. Third is most of the anti-epileptic, of which valproic acid is very important. That causes pancreatitis. Diuretics like furosemide and thiazide group of diuretics both causes pancreatitis. In fact, all those lipid lowering drugs like statins, they also cause pancreatitis. So third is the drug. The fourth is iatrogenic. You know what iatrogenic means? Means done by that somebody who is treating. So you must have heard about removing the stones in the bile duct by doing an endoscopy. Suppose there is a stone there in the gallbladder, there is a stone there. So what is the treatment of this stone? We do preoperative, what is called ERCP. That is endoscopic retrograde cholangiopancreatography. That means we come from here, এটা চলে যাচ্ছে তো স্টমাকে, এখান থেকে এখানে এসে এই স্ফিনটারটা এই প্যাপিলাটাকে একটু কেটে বড় করে দেওয়া হয়, একটা বাস্কেট ঢুকিয়ে এই স্টোনটাকে এই দিক দিয়ে বের করে দেওয়া হয়. So when we actually doing a papillotomy, because without doing papillotomy you can't take out the stone, how small it is, but it is preferentially the tendency of the guide wire has a tendency. There are two ducts there, you see. When it is a side viewing endoscope, it is not end viewing. মানে ক্যামেরাটা মাথায় থাকে হচ্ছে তো যেগুলো আপার যে এন্ডোস্কোপি করে স্টমাক ডিওডেনাম দেখার জন্য, বাট ফর ইআরসিপির জন্য ক্যামেরাটা থাকবে এখানে, মুখটা এখানে, ক্যামেরাটা সাইড ভিউইং যাতে এটা ভালোভাবে দেখা যায়. You understand? So এটাতে যখন প্রথমে একটা গাইড ওয়ার ঢোকানো হয়, so guide wire usually goes into the pancreatic duct, and then you give contrast to see where exactly you are going. So the multiple contrast that is given, বারবার যদি তোর pancreatic duct যায় and the endoscopist is not skilled enough, so you will keep on giving dye to check where it has gone, pancreatic duct or bile duct. Target is to go into the bile duct, but the tendency and the lie of those ducts are so that it easily goes into the pancreatic duct. So multiple failed attempts, and each time you give contrast, that actually provokes pancreatitis. So ERCP is a major cause of pancreatitis. So gallstone alcohol together 80%, drugs is very important 5 to 10%, iatrogenic is about 5%. So that's why this is, I have written it in the order of frequency. Another important, any surgery, there is an entity called post-operative pancreatitis, but couple of surgery are more importantly, are intimately related to this. One is gastrectomy. So when you do a total gastrectomy, many patients subsequently develop pancreatitis. So iatrogenic is mostly ERCP ta mone rakhte hobe. Then we come what is called metabolic. There are certain metabolic diseases that can cause pancreatitis. You janis ki metabolic disease? Yeah. Yeah. Hyperglycemia ta bolbi na, hyperglycemia is an effect. So hypercalcemia কিসে হয়? প্যারাথাইরয়েড হরমোন যদি তোর অ্যাডিনোমা হয় তখন হাইপারক্যালসিয়াম বা ভিটামিন ডি টক্সিকোসিস যদি হয়, so that is hypercalcemia causes pancreatitis. And hyperlipidemia, অনেকগুলো ভ্যারাইটি আছে, টাইপ 2 and 5 especially, they causes তোর pancreatitis. The sixth one is toxin. Toxins means scorpio bite, wasp bite, organophosphorus poisoning যাদের হয়, তোরা পরে এমার্জেন্সিতে দেখবি অনেকেই গ্রামের দিকের মহিলারা বিশেষত ওই ইনসেক্ট পেস্টিসাইড হিসেবে অর্গানোফসফরাস রাখে, and very important তোদের মেডিকেল এমার্জেন্সির মধ্যে হচ্ছে অর্গানোফসফরাস পয়জনিং, স্পেশালি ইন দ্য রুরাল ব্যাকগ্রাউন্ড, দ্যাট ইজ ভেরি কমন. ইন দ্য আরবান সুইসাইডেরও দুটো প্যাটার্ন আছে, রুরাল প্যাটার্ন, আরবান প্যাটার্ন. রুরাল অর্গানোফসফরাস, আরবানস আর মোস্টলি মিউরিয়াটিক অ্যাসিড পয়জনিং, তাদের ইসোফেজিয়াল স্ট্রিকচার হয়. So organophosphorus যে এগুলো আছে, that is also toxin, so that causes this thing. And the seventh one is the infective. You know, infective, in the part of infective you can say all the name of the abnormal viruses. কঠিন ভাইরাসের নামগুলো পড়েছিস তোরা তো প্যাথোলজিতে, কক্সেকি বি ভাইরাস, এপস্টেইন বার ভাইরাস, cytomegalovirus. So all three of them are known to cause pancreatitis. SLR, Legionella and Salmonella. These two also can cause pancreatitis. না না আমি বলছি ভাইরালটাও ইনফেকশন, ব্যাকটেরিয়াল ইনফেকশন। আমি সবগুলো ভাইরাল ইনফেকশন তো বলিনি, ভাইরাল তিনটে বললাম, তার সাথে দুটো হচ্ছে হেপাটাইটিস ভাইরাস, বোথ হেপাটাইটিস এ অ্যান্ড বি, সাইটোমেগালো, কক্সিকি বি, এপস্টেন বার্ড। ব্যাকটেরিয়ালের মধ্যে ইনফেক্টিভের মধ্যে তাহলে কি ভাইরালই হয় নাকি? তাহলে তো আমি যদি বলি যে ইনফেক্টিভের মধ্যে যদি একটা সালমোনেলা বলি, ইজ ইট রং? দ্যাট ইজ ব্যাকটেরিয়াল বাট ইট ইজ স্টিল ইনফেক্টিভ। So that's that. Then you come to the neoplasm. Couple of neoplasm can cause pancreatitis, of which one of them you need to remember, and this can come as a short note also. Intraductal pancreatic mucinous neoplasm. হ্যাঁ, এটা একটা স্পেশাল এন্টিটি। অনেকটা তোরা যে ব্রেস্ট কার্সিনোমার সময় যেমন ডিসিআইএস পড়েছিস, so most of the, so it is equivalent to DCIS. This is a separate entity that causes these pancreatitis. Apart from that, carcinoma head of the pancreas, that also can cause pancreatitis. Then there is an autoimmune disease. Autoimmune disease মধ্যে Sjogren syndrome, এছাড়া SLE, I don't know that, maybe you are right. What I know is Sjogren syndrome, SLE, these are the autoimmune disease that predisposes to pancreatitis. And the last one I have written in red, and that is called idiopathic. So you know, basically মাঝের গুলো তুই ভুলে যা, pancreatitis patient আসলে তোর কাছে তিনটে you need to possibility. gallstone pancreatitis, যেটাকে আমরা বলি biliary pancreatitis, একটা হচ্ছে নন বিলিয়ারি অ্যালকোহলিক প্যানক্রিয়াটাইটিস, আরেকটা হচ্ছে উই ডোন্ট নো হোয়াট কাইন্ড অফ প্যানক্রিয়াটাইটিস অর ইডিওপ্যাথিক। বাট ইন এভরি কেস অফ প্যানক্রিয়াটাইটিস ইউ নিড টু ট্রাই টু ফাইন্ড এ কজ, because if you can find a cause like alcoholism, then at least you can know, you stop the offending agent and so that it never recurs again. Or there is a gallstone or a bile duct stone, then you remove the bile duct stone and do the cholecystectomy so that it doesn't happen again. So idiopathic is very important. So 80% gallstone alcohol and rest 20%, most of the time it will come back as idiopathic. So but there are a couple of etiologies that you need to know. Now what are the diagnosis? Diagnosis কি করে করবি? ডায়াগনোসিসের জন্য তিনটে জিনিস আছে, একটা হচ্ছে টিপিক্যাল হিস্ট্রি, একটা হচ্ছে বায়োকেমিক্যাল মার্কার্স, আর একটা হচ্ছে রেডিওলজিক্যাল ইমেজিং। এই তিনটের মধ্যে যে কোনো দুটো থাকতে হবে, আদারওয়াইজ ইউ ক্যানট স্ট্যাম্প ইট অ্যাজ প্যানক্রিয়াটাইটিস। শুধু যদি একটা লোকের একটা অ্যামাইলেজ লাইপেজ বেশি থাকে তার মানেই তার প্যানক্রিয়াটাইটিস হয়েছে তুই বলতে পারবি না, আনলেস দের ইজ এ টিপিক্যাল হিস্ট্রি। সো হোয়াট ইজ দ্য টিপিক্যাল হিস্ট্রি? Typical history of pancreatitis, patient will come with a history of sudden onset upper abdominal pain, mostly in the epigastrium, typically radiating to the back, associated with severe nausea, and more nausea than vomiting. বারবার ইরাকটেশন হয়, ওয়াক ওয়াক করতে থাকে। He may not throw up lot of stuff, but he will continuously keep on doing this eructation. So this is the typical description. That means a male patient or a female patient comes with sudden onset epigastric pain with radiation to the back associated with nausea and vomiting. That means you should think of pancreatitis. এর মধ্যে আমি যদি রেডিয়েশন টু দ্য ব্যাকটা বাদ দিয়ে দিই তাহলে আর কোনো ডায়াগনোসিস আসবে? বাকিটা সমান। একটা ধর একটা 40-year-old male patient comes with sudden onset epigastric pain associated with nausea and vomiting. পারফোরেশন কথাটা বলতে হবে, সাডেন অনসেট কথাটা পেপটিক আলসার রাস্তায় 100টা ঘুরে বেড়াচ্ছে। আর দে কামিং টু এমার্জেন্সি, one of them will come when that peptic ulcer perforates, and that is called peptic ulcer perforation. So that actually presents male patients. সেই জন্য গলস্টোনটা বলবি না, গলস্টোনের সাডেন অনসেট ওরকম খুব রেয়ারলি হয়, বলতে পারিস, বাট অবভিয়াসলি দের আর তিনটে জিনিস আসবে এরকম সাডেন অনসেট এপিগ্যাস্ট্রিক পেন মেল পেশেন্ট যদি তোকে বলে, প্যানক্রিয়াটাইটিস, পারফোরেশন। আর আমাদের এখানে এই রোগটা হয় না, বিদেশে এটাকে তোকে মিস করলে তোর রেজিস্ট্রেশন চলে যাবে, সেটা হচ্ছে ruptured aortic aneurysm. সেখানে কিন্তু ব্যাক পেন হয়। সো অ্যানিউরিজম, রাপচার্ড অ্যাকিউট অ্যাওর্টিক অ্যানিউরিজম আর প্যানক্রিয়াটাইটিসের মধ্যে ডিডি করা খুব ডিফিকাল্ট হয়ে যায়। So this is the typical history. Now you come to the second part, and that is the markers. You know the markers are amylase and lipase, of which amylase starts immediately within few hours of the onset of the pain. আমার এখন প্যানক্রিয়াটাইটিস হলো 1-2 ঘন্টার মধ্যে অ্যামাইলেজ বেড়ে গেল, and it comes down to normal within 5 to 7 days. Even if my pancreatitis goes on increasing in intensity, amylase will become normal. So when patients come early, then there is significance of amylase, serum amylase. But amylase is not very specific for pancreas because it is also secreted by the salivary gland. So hyperamylesemia can happen in many other diseases other than pancreatitis, like peptic ulcer perforation, intestinal obstruction, ectopic aneurysm, ectopic pregnancy, and acute appendicitis, sialoadenitis. So all these can cause hyperamylesemia. So that's not very specific. What I want you to remember that it is an enzyme that goes early in the disease and comes back to normal within 5 to 7 days. In contrast, lipase is something, it goes up slowly and stays up. So একটা পেশেন্টের ধর 5 দিন আগে ব্যথা শুরু হয়েছে, তোর কাছে 5 দিন পরে এসেছে, so you won't be surprised if you see his amylase is normal but his lipase is reasonably high. So between amylase and lipase, lipase is more reliable than amylase. একটা জিনিস আমি ক্লিয়ার করে দিতে চাই, এই amylase lipase has got some value in the diagnosis because these are the markers, but it has got no value on three things. It has got no value on the etiology of pancreatitis. আমরা 10টা ইটিওলজি লিখেছিলাম, অ্যামাইলেজ লাইপেজ 10টাই বাড়বে, তুই বাড়লে বলতে পারবি না এটা গল ব্লাডারের জন্য প্যানক্রিয়াটাইটিস হয়েছে। সো ইট হ্যাজ গট নো ভ্যালু অন ইটিওলজি, নো ভ্যালু অন সিভিরিটি অফ প্যানক্রিয়াটাইটিস, দ্যাট ইজ ভেরি ইম্পর্টেন্ট। অনেকেই দেখবি তোদের কি অনেক সিনিয়র রেসিডেন্টসরা বলে যে স্যার ওর অ্যামাইলেজটা প্রচুর বেড়ে আছে 10 দিন পরে। ইট হার্ডলি ম্যাটার্স অ্যামাইলেজ বেড়ে আছে না কমে গেছে, বিকজ ইট হ্যাজ গট no value in prognosis, no value in etiology, and no value in determining the severity of the pancreatitis. So this is the second one. আমি এর সাথেই বলে দিই, then what are those things which are valuable to diagnose severity and pancreatitis? মোটামুটি একই মার্কার হবে, যেটা সিভিয়ার হবে সেটা প্রগনোসিস খারাপ হবে। So those markers are the acute phase substances. যে তিনটে অ্যাকিউট সাবস্টেন্স বেরোয়, একটা হচ্ছে তোরা মনে পড়েছিস সিআরপি, সি রিঅ্যাক্টিভ প্রোটিন, টিউমার নেক্রোসিস ফ্যাক্টর আলফা, and interleukin 6, of which it is easy to measure the CRP. So that is used as a marker. তো যখনই প্যানক্রিয়াটাইটিস আসবে একটা বেসলাইন সিআরপি তুই করে নিলি, দেখলি বেড়ে থাকবে 4-6 যাই হোক, সেটার এগেনস্টে তুই সিআরপিটা মেজার করে প্যানক্রিয়াটাইটিসের সিভিরিটিটা অ্যান্ড প্রগনোসিস খানিকটা জাজ করতে পারবি। But there are other tumor necrosis factor alpha and the other one I said interleukin 6, and the third one is radiology. So radiology te kon investigation kora hoy? As usual, always you should go for ultrasound because it is an extension of clinical examination. It is easily available, low cost, no radiation hazard, but ultrasound has got good value in evaluating the biliary tree, but it has got very dicey value in judging the anatomical aspect of the pancreas. But still, it actually gives you a very important clue whether the patient has got gallstone or bile stone or anything, because that contributes to about 60% of all cases of pancreatitis. So first is the ultrasound you will do, and in 40% cases, because of the overlapping duodenum, bowel gas and everything, you cannot even see the pancreas at all. So don't think that the radiologist is bad, but these investigations still to be done. তাহলে তোকে এক্সামিনে যে কেন তুমি আল্ট্রাসাউন্ড করবে যদি প্যানক্রিয়াস দেখতেও না পাই, তুই বলবি I can easily see the gallbladder and biliary tree, and this is the most common cause of pancreatitis. So that should always help me. And আমি নেগেটিভটাই ধরবো না, 60% কেসে you can easily evaluate if there is any pancreatitis, peripancreatic fluid collection, pseudocyst, these can be picked up. So first is ultrasound, and the second one is most important, that is called contrast enhanced CT scan. So these are the CT scan has got very important value. It delineates the pancreatic anatomy very well. It can also tell you whether there is other complications, local complications of pancreatitis, and there is a separate scoring system based on the CT scan finding that is called Balthazar score. But that was the old score. Now they have gone into a CT Severity Index, which will come. These have got some value. Normally, I don't encourage you to go through all these different scales and scores, but for pancreatitis, you will have to remember two at least. One is Ranson score, and Glasgow you don't have to remember, either Ranson and the CT Severity Index. And more importantly, what is the importance of this score? How they beautifully correlate with the mortality. So, Tora jokhon doctor hobi, what is the purpose of all this shouting and teaching and everything? You will become a doctor, somebody will come as a patient, what he is interested in. তোর কাছে পেশেন্টটা আসার পর তোকে কি বলবে ডাক্তার হিসেবে? ডাক্তারবাবু আমার রোগীটা কি কি হবে, কেমন ভালো হয়ে যাবে তো? সো বিফোর ইউ সে ইয়েস, তো সবসময় চাইবি সবাইকে বলবি ভালো হয়ে যাবে, বাট দ্যাট ইজ নট ট্রু, বিকজ ইফ ইউ গেট এ প্যানক্রিয়াটাইটিস হু হ্যাজ গট সিভিয়ার অ্যাকিউট প্যানক্রিয়াটাইটিস, you should not say that bhalo hoye jabe. You say he has got severe acute pancreatitis which carries a definite mortality risk of about 40%, and it has got a very unpredictable course of action and no active treatment as such in the form of surgery or anything. So I won't be able to tell you that bhalo hoye jabe ki jabe na. I am doing the scoring and I will tell you that his score is this, so bhalo howar sombhobonata beshi na kom. So that's why lie the importance of scoring, which I will come back later. So always remember, to stamp a patient as someone suffering from acute pancreatitis, you need to have any two of these three. So suppose a patient comes with a typical history of pancreatitis, sudden onset pain, epigastrium, radiation to the back associated with nausea, vomiting. Usually the upper abdomen is involved, but as the disease progresses, the lower abdomen and the whole of the peritoneum become very tender, so it mimics perforative peritonitis. In our younger days, when ultrasound were not very easily available, neither was amylase and lipase. In many cases, we, as a surgeon, you need to be interested to go and cut the abdomen so that you learn when we were house staffs in emergency. So sudden onset pain, we used to think that this is peptic perforation, because in our time, peptic perforation was very high, because at that time, ranitidine has not even come in. So a lot of people suffers from peptic ulcer disease, and many of them used to perforate. So that was the first operation that every surgical resident used to interested to do. So we used to cut lot of patients, and then we used to see there is saponification. Tora jeta dekhisni, why the calcium goes down during pancreatitis? Because lipase breaks the fat into fatty acid, and calcium joins with the fatty acid, and thereby lowering the blood calcium level. So otar ekta typical একটা দেখলেই তুই বুঝতে পারি, the moment we cut, lot of fluid used to come out, and we could see that this is pancreatitis. So we closed the abdomen because nothing you can do, and we lost many patients in those time, because if you can diagnose pancreatitis, you should suddenly go in for immediate surgery, because that actually spoils the chances of patient survival. Okay, so যার একটা হিস্ট্রি আছে অথচ অ্যামাইলেজ লাইপেজ নরমাল, তখন তোকে আল্ট্রাসাউন্ড বা সিটি করে কনফার্ম করতে হবে, যে কোনো দুটো অফ দ্য থ্রি। নাও আই এম কামিং, হুইচ ইজ নট দেয়ার ইন দ্যাট স্কেল। আমি সিভিরিটির জন্য এটা হচ্ছে মাইল্ড, এটা কিন্তু ইন্টারন্যাশনাল ক্লাসিফিকেশন। মানে মাইল্ড প্যানক্রিয়াটাইটিস মানে কি, যে there is evidence of pancreatitis, so either the history is there or amylase lipase is there, so I have stamped it that the patient has got pancreatitis. But I am saying it's mild because two things are absent here. What are those two things? First thing is organ dysfunction. Organ dysfunction. And the second one is local complications. These two are very important to judge. So I will come back to what are the local complications that we talk about. So in mild pancreatitis, it is a proven case of pancreatitis, but somebody who doesn't have organ dysfunction, any organ dysfunction, and local complications. So organ dysfunction is the central thing which will tell you whether the patient will do good or bad. So organ dysfunction means pancreatitis can involve all the organ, of which two is very important. One is the pulmonary function, the other is renal function. But with time, it involves the cardiac function and also nervous system, brain function. So many pancreatic patients can actually behave like a psychotic, agitated and all. That is very difficult to judge whether it is an alcohol withdrawal or psychosis of pancreatitis. So what is important, organ dysfunctions means there is involvement either of pulmonary, renal, cardiovascular or central nervous system, of which pulmonary and renal is very important. তোকে এক্সামিনার অনেক সময় জিজ্ঞেস করতে পারে, আচ্ছা বলো তো তোমাকে যদি একটা জিনিস জানতে চাওয়া হয়, একটা পেশেন্ট প্যানক্রিয়াটাইটিস হয়েছে, একটা জিনিস জিজ্ঞেস করবে, তাহলে তুমি কি জিজ্ঞেস করবে? Lot of people ask, I'm talking about lot of investigation and everything. Yes, they are important. But what is very important, an examiner wants to hear from you, that you will ask, what is your urine output? So whatever is happening inside the body that you can pick up with these tests, that test, the end result is the urine output. If a pancreatitis patient has got an urine output, say 1 milliliter per kg per hour, then I am reassured that in most likely he will be doing okay. But if somebody who has got an urine output which is less than 0.5 ml per kg per hour, then I know there is problem. So this question you must remember, one parameter which you want to know, jeta bedside e dekha jay, তখন urine output will be the answer, not any CT scan and this and that. So organ dysfunction is absent and local complications. Pancreatitis can cause some local complications in the form of peripancreatic fluid collection, fat stranding. There may be that, what is that called? Pseudopancreatic cyst. Okay, necrosis, infected necrosis. These are all local complications. That means around the pancreas. And there is away from pancreas, distal extra pancreatic complications that are called organ dysfunction. So that means there is no local complication, there is no systemic complication, but patient has got pancreatitis, we call it mild. Now come to the next one, what is moderately severe? Moderately severe means mild plus transient organ dysfunction of less than 48 hours. Means mild এর সাথে there will be transient organ dysfunction, মানে আমি কিডনি দিয়ে যদি বলি ইউরিন আউটপুট, হয়তো প্রথমের দিকে খুব ইউরিন আউটপুটটা কমে গেল, but with fluid, lot of fluid, the urine output goes up. So whatever it corrects within 48 hours. These hours are important in the international classification. So you can't vary it, 36 ঘন্টা বলা যাবে না. So within 48 hours, if there is a organ dysfunction will be there, but that will be transient and will be corrected with treatment within 48 hours. That means it is moderately severe. And of course the severe is permanent. That means organ dysfunction is not being reversed within 48 hours with energetic conservative treatment. So that is called severe. Now how the mortality is correlated with this, we will come later on. Now important adjunct investigation আমি কতগুলো বলেছি, ফার্স্ট হচ্ছে অ্যাকিউট ফেজ সাবস্টেন্স যেটা দিয়ে প্রগনোসিস দেখে, তারপরেরটা হচ্ছে সিরাম ক্যালসিয়াম, দ্যাট ইজ ভেরি ইম্পর্টেন্ট. Hypercalcemia causes pancreatitis, pancreatitis causes hypocalcemia. So calcium level goes down, so you should regularly monitor serum calcium level like any other electrolytes. It is required for monitoring pancreatitis. The third one is liver function test. That is very important because if you see that the bilirubin is high, the enzymes are high, the alk phos is high, that means there is possibility that the patient has got biliary pancreatitis. So if you find that, and if you do an ultrasound and you see there is gallstone and CVD is dilated, then immediately you send the patient for ERCP, because gallstone pancreatitis is one pancreatitis where if you get early, then you can intervene in the form of ERCP and removal of the CVD stone. But that is possible ideally within 48 hours of the onset of the disease and 10 to 72 hours, but never later than 72 hours. So that is, there lies the importance of LFT. And then is the ABG. The arterial blood gas in case of severe acute pancreatitis, you will have to regularly, at least 12 hourly arterial blood gas is to be done for severe acute pancreatitis. Now let's come to the Ranson scoring. So the 11টা class হচ্ছে না? Ranson scoring, this is very important. যদি পড়তে পারছিস, you know, প্রথম কথা হচ্ছে this scoring you must remember. And this scoring is not a scoring আমি তোর কাছে আমার একটা রোগী আসলো, আমি ব্লাড পাঠালাম, ব্লাড রিপোর্ট পেলে সঙ্গে সঙ্গে বলতে পারবো না. You will have to wait for at least 2 days because certain blood criteria are there at admission, on admission, বাঁ দিকের গুলো, and after 48 hours ডান দিকের গুলো. So on admission কি criteria আছে? First হচ্ছে age. Age more than 55, he will get 1 point. Total count more than 16,000, he will get 1 point. Blood glucose level more than 200 mg/%, he will score 1. Aspartate aminotransferase AST more than 250, he will get 1 point. And lactate dehydrogenase more than 350, he will get 1 point. These are the 5 things that are measured at the time of admission. So you send those bloods. Now you can't score immediately. You will have to wait for 48 hours, and after 48 hours you send the rest of it. These are very important. You send calcium. If the calcium level is less than 8, the patient will score 1. Here scoring 1 is bad for the patient. You know, the score goes up, patient's chances of survival goes down. So calcium you measure after 48 hours. And then you measure hematocrit fall. The fall of hematocrit, if it is more than 10%, then the patient will get 1. And PCO2, if it is less than 60 millimeter of mercury, PO2, I apologize. So PO2 is less than 60, then patient score 1. Then there is base deficit of more than 4, then patient gets 1. Then blood induced nitrogen increase, if it is more than 5, then patient get 1. And if the sequestered fluid volume is more than 6 liter, patient get 1. That 4, 5, 6 ভ্যালু গুলোকে একসাথে রেখে দিবি, তাহলে মনে থাকবে 4 মানে হচ্ছে বেস, 5 যেটা হচ্ছে ব্লাড ইউরিয়া নাইট্রোজেন, 6 হচ্ছে সিকুয়েস্ট্রেটেড ফ্লুইড ভলিউম, আর উপরে তাহলে পড়ে থাকবে তোর PO2, hematocrit fall and calcium. So you do a total score and you see if the score, so after 48 hours you can talk to the and face the relative with your score and say what will happen to him. If the score is between 0 to 2, then the mortality is very low, 2% practically. So you will say ভালো হয়ে যাওয়ার সম্ভাবনাটাই বেশি. So the last one is important, 0 to 2. তোদের এই লেখাটা পড়তে অসুবিধা হচ্ছে, আই এম সরি, এটা কেন এরকম হচ্ছে বলতো? 0 to 2 is 2%, 3 to 4 যদি হয় mortality will be 15%. So still better, মন্দের ভালো. But if the score is between 5 and 6, the mortality is 40%. But what is important, if the score is more than 6, the mortality goes up to 90 to 100%. So it is very important, before you talk to the patient, you need to have some kind of a patient আর কতটা আপনাদের কি Throughout the severity of pancreatitis, you should not be judging how much pain the patient is having. That is one criteria, but not all. So, if, the second, okay, so then the CT Severity Index. এটাও যদি পড়িস, এটা ব্যালথাজারের পরে করা হয়েছে, এটা একটা ইউনানিমিটি আনার জন্য এই কতগুলো ক্রাইটেরিয়া দেওয়া হয়েছে। বেসিক্যালি এটাতে দুটো জিনিস দেখা হয়, একটা হচ্ছে প্যানক্রিয়াটিক অ্যানাটমিটা দেখা হয়, আরেকটা হচ্ছে নেক্রোসিসটা দেখা হয়। সো নেক্রোসিসটার মধ্যে তোর স্কোরিং কিভাবে হবে? ইফ there is no pancreatic necrosis মানে জানিস তো, when there is severe inflammation, this is very important, a part of the pancreas become devascularized and they basically die. There is no contrast enhancement, যার জন্য কন্ট্রাস্টটা দেওয়া হয়। কন্ট্রাস্টে যে জায়গাটা ডেড টিস্যু সেটাই এনহ্যান্সমেন্ট হবে না। সো নন এনহ্যান্সড এরিয়া মিনস there is necrosis. সো ইন প্যানক্রিয়াসে যেখানে কোনো নেক্রোসিস নেই সেখানে স্কোর হবে 0, যেখানে লেস দেন 30% অফ দ্য প্যানক্রিয়াস ইজ ইনভলভ সেখানে স্কোর হবে 2, আর যেখানে 30 to 60% সেখানে হবে 4, আর এর পরেরটা কিন্তু মোর দেন 50% সেটা হবে 6। এটা হচ্ছে অন দ্য বেসিস অফ নেক্রোসিস, অ্যান্ড ওপরের গুলো হচ্ছে অন দ্য বেসিস অফ অ্যানাটমি, অর্থাৎ নর্মাল প্যানক্রিয়াস, দের ইজ নো এনলার্জমেন্ট, ইডিমা, সোয়েলিং, পেরিপ্যানক্রিয়াটিক ফ্লুইড, নাথিং। সো they will get 0. Enlargement of the pancreas, they will get 1. Peripancreatic inflammation, they will get 2. If there is 1 acute peripancreatic fluid collection, then he will get 3, and if it is 2 or more, then he will get 4. So you see total score will be around 10, I think. Maximum 10, minimum 0. And here also the prognosis যেটা এই স্লাইডে নেই, এটারও prognosis হচ্ছে এটাতে 3 দিয়ে করা হয়। So if the CTSI মানে CT Severity Index, if the value is say 3, 0 to 3, এটাতে mortality, so 3, 4 to 6, mortality 6, more than 6, এটা হচ্ছে more than 6 to 10 actually, এটাতে হচ্ছে 17. So here also there is a correlation with the mortality. So everything, each time you do a scoring, and the base is to say what will be the fate of the patient. So these two you remember. এটা পড়ে দেখবি এটাতে অনেক সময় 50%টা লেখা থাকে না, এই লাস্টে যেটা আছে 50% এর জায়গায় লেখা আছে if there is any extra pancreatic organ dysfunction in the form of say bilateral pleural effusion আছে বা ascites আছে, then they will get 2 points. But anyway, they are different, but something like this that you need to remember. Glasgow Coma score খালি, sorry, Glasgow Coma score বলছি, Ranson score তোকে কালকে ঘুম হয়নি না, not a single 1 মিনিটও ঘুমোতে পারিনি তোর Ranson score প্রত্যেকটা ভ্যালু মনে রাখবি, and you must remember that it is a scoring to be done in 2 phases, on admission and after 48 hours. So I can't say immediately by a single way what will be the prognosis. Okay, now say complications, of which এই পুরো pancreatitis এর মধ্যে কমপ্লিকেশনসটা আমি কমপ্লিকেশন আর ট্রিটমেন্ট আমি পরের দিন পড়বো। ইউ নিড টু গো এ লিটল বিট, সবকিছু সুপারফিশিয়াল টাচ করে গেলে তো কোনো লাভ হবে না। কমপ্লিকেশনস এর মধ্যে দুটো জিনিস মনে রাখবি, একটা কথা হচ্ছে নেক্রোসিস আছে কি নেই, 2 নম্বর হচ্ছে whether the necrosis is infected or not, অর্থাৎ স্টেরাইল নেক্রোসিস or infected necrosis, আর 3 নম্বর হচ্ছে organ dysfunction. So necrosis plus it is infected, there is organ dysfunction, mortality is 80% at least. তার মানে তুই প্যানক্রিয়াটাইটিসের জন্য সিটি স্কোরে দেখতে চাইবি অন্য কিছু নয়, কত জল জমে আছে, জল সবসময়ই জমবে, চারিদিকে জল জমে আছে। ইউ নো ইন এ প্যানক্রিয়াটাইটিস পেশেন্ট you will be surprised that on admission sometimes you need to give how much of fluid, 10 liters to 25 liters within 24 hours. 10 liters to 25 liters. Lot of fluid is to be given because all the fluid is sequestrated into the third space. Not only in the, there are several potential spaces in our body like peritoneum, there is pleura, there is retroperitoneum, and there is interstitial tissues. So that is called third space loss. There is a huge amount. So in pancreatitis, what fluid you will give, that is not to be discussed. You have to give something which is osmotically active. So electrolyte solution, not plain dextrose. So give ring-alerted, give it. So that's why pancreatitis is called, it is the burn of the retroperitoneum. Just like in burn treatment, you need to douse the flame with water. In pancreatitis, you will have the courage to give lots and lots and lots of fluid. Sometimes sisters will say, how much you are giving? So you say, I will not stop till I get a good amount of urine output, or I have pumped in at least 10 liters of fluid in 24 hours. And it is called the burn of retroperitoneum. Next day, we will come into the complications and treatment bit. Any questions on what I have taught today? So ঘরে গিয়ে তোরা কোন বই পড়িস জানি না, but belly love পড়বি. That's what I hope. And always remember, pancreatitis hole, it is a fatal disease. You know, Maradona in his lifetime, the people were burning Mombatti because he had pancreatitis. Lot of famous people died of pancreatitis. And what you are interested in, but assurance is 80% is innocuous. It is only the 20% they are bad. And of which those who have got necrosis, they are bad. Those who are necrosis is infected, they are worse. And those necrosis infected when associated with organ dysfunction, they are the worst. So that you must remember. Thank you very much.